Hello and welcome to my lecture on Y90 therapy for liver cancer. This lecture is only for educational purposes. I do not claim any originality. I am going to acknowledge my resources in the next two slides. The first is by Camacho et al., an article that was published in Radiographics, a very useful article. And the next one is an article that was published in Journal of Gastrointestinal Oncology, and again I found it to be an excellent article. This is only for teaching purposes, and I do not claim any originality. I want to give you a little background about liver cancer, hepatocellular cancer, which is an aggressive primary malignancy of the liver that typically presents late in the disease course, and most of the time the patients are not good candidates for curative therapies, and as a result one is reduced to getting local regional therapies such as with yttrium radioembolization, um, that has started playing a big role in the treatment of vast majority of such patients. Um, Now, typically hepatocellular carcinoma is associated with chronic liver disease and cirrhosis. It is an aggressive malignancy. It is identified late in the course of the disease and has a median survival of only 6 to 20 months. Tumor resection and liver transplantation are the only two potentially curative therapies. Now, it is important to understand that before we start treating patients, we need to understand the liver function, the size of the tumor, whether there is involvement of the portal vein and hepatic veins, any metastatic disease, and only about 10 to 20% of the patients are eligible for curative therapy. The local regional therapies have a critical role in patient management with hepatocellular carcinoma. Now, trans-arterial chemoembolization or TACE and radiofrequency ablation are two therapeutic modalities that are available. Now, radioembolization with yttrium is a safe and effective therapy both for primary and metastatic liver cancers. It is important to understand that the hepatocellular carcinoma is a radiosensitive tumor, and one can give external beam radiation, but the problem is the resultant hepatic toxicity. Beyond the dose of 30 gray, the liver cannot tolerate external radiation therapy because of the damage that it causes. And as a result, it is not the best treatment. Now, in case of radioembolization, we are using a directed technique where the microspheres are delivered into the branches of the hepatic artery. These are embedded in yttrium. Now, yttrium is a pure beta emitter with an average energy of 0.9 MeV. Its penetration range is 2.5 millimeters, so it can penetrate about 1,000 cells. It has a half-life of 64.2 hours and it decays to stable zirconium 90. Now, the microspheres vary in size from 20 to 60 microns, which are embedded with yttrium. There are two forms of therapy available in the United States. One is the glass microspheres, they are called TheraSpheres, and then there is one which are resin based or called spheres or microspheres. Now, I'm going to be repeating some of this information 2-3 times. Now, hepatic malignancies derive their blood supply from the hepatic artery, not from the portal vein. So, if selective catheter administration of yttrium 90 microspheres into the hepatic artery is done, it can spare normal parenchyma of the liver, whereas it will deliver the therapy only to the tumor, which is supplied by the hepatic artery. And by using this technique, one is able to deliver 50 to 150 grays. When we compare it to the external beam radiation therapy, we can only give 30 gray, whereas in this case, doses up to 150 gray can be delivered. So that's a great advantage. Now, the mechanism of action of embolization differs from TACE in several key aspects. TACE particles are much larger than microspheres, 200 to 500 microns versus 20 to 30, and as a result, TACE exhibits a more significant embolic effect. The primary mechanism of action of yttrium is believed to be the radiation effect with a minor role of the embolic occlusion. So it's an important distinction you must understand. TACE uses microembolize to kill the cells, whereas yttrium 90 microspheres, the effect of embolic occlusion of the arteries is less. It is more of the radiation effect that is of use. Now, what do we do before we start treatment? So there is a pre-procedure planning that is involved, comprehensive history and physical exam, routine labs, baseline imaging, and we want to stage the tumor, see the extent of the primary lesion. We want to have a performance status of the liver, and any constitutional symptoms, any involvement of the hepatic artery portal veins, and any distant metastasis. So we do a CAT scan, MRI of the abdomen. We plan celiac and hepatic angiography to see the anatomy, and hepatic and artery and its branches that are supplying the tumor are identified. And if there are any collaterals branching from the hepatic artery supplying the gallbladder, stomach, or intestine, these are embolized to avoid any secondary complications. Now, this is a key. Um, you must understand this, that if there are any collaterals, they need to be embolized prior to definitive therapy. And if these are not amenable to call embolization, then it is a contraindication to give yttrium therapy. Um, Again, talking about the pre-procedure planning, we use technetium 99M macro-aggregated MA particles, which are injected via the hepatic artery, and a whole body nuclear scan is done to see the extent of shunting to the lungs and elsewhere in the body. MA particles are chosen because they have a size which is similar to the yttrium 90 microspheres. Now, this is done to avoid any excessive shunting to the lungs and resultant radiation damage. Now, if the shunt is to the lungs is there, then we have to reduce the dose accordingly, or perhaps not even give dose if there is a large shunt to the lungs. Now, the tumor response can be assessed by sonography, CT, or MR scans, and you can use modified RECIST. And then, of course, how do we define responses? Complete responses if there is a disappearance of any intratumoral arterial enhancement. Partial is if there is more than 30% decrease in the sum of the diameter of the viable target lesion. Progressive disease is defined as more than 20% increase in the diameters of enhancing target lesion or a new lesion. Stable disease is defined as any tumor response between PR and PD, and if the patient expired before repeat imaging could be performed, they are considered to have a PD or progressive disease. Um, the activity of the 90Y microsphere depends on the tumor burden, the volume of the liver to be treated, the type of microspheres that are going to be used, the shunt to the lungs, and then of course we plan the treatment, which requires CT and MR imaging, and we calculate the tumor size and the tumor-free volumes of the liver, whether the portal vein is involved or not, whether it is patent or not, and if there is any extrahepatic involvement. SPECT and SPECT CT imaging is done to identify any abnormal imaging patterns. These are corrected with catheter repositioning and selective embolization of those branch vessels. Uh, and after the procedure, confirm the appropriate delivery of 90Y microspheres by SPECT and SPECT CT. And again, this is to identify any abnormal distribution and potential complications. And this will also be helpful in any future therapies. Now, how does this agent act? So yttrium is a deep is obtained is yttrium is a decay product of strontium 90, and it can be produced by neutron bombardment of yttrium 89. Now, this is a pure beta particle emitter. It decays to zirconium, and it has a half-life of 64.1 hours, which is equal to 2.7 days. Average energy is 0.9 MeV, and it will cause cell death in surrounding tissues at appropriate activity. I mentioned that conventional radiation therapy is limited to only 30 gray, beyond which the liver cannot tolerate it. But we require 70 gray of radiation to kill and destroy the solid tumors. So that is where these intra-arterial radiation becomes more effective. Again, a repetition of the same process that I'm talking about. The liver parenchyma can only tolerate 30 to 40 gray. Beyond 40 gray, there is a chance that there will be liver damage. Although most liver cancers are radiosensitive, the liver cancers have a predominant hepatic arterial blood flow and not portal venous supply. And when we give microspheres, they concentrate within the tumors and cause radiation cell death and spare the normal liver parenchyma. A few words about these two types of microspheres. The glass microspheres are called therasphere. They are in this, the yttrium is incorporated into the glass matrix. The size is 20 to 30 microns, specific gravity is 3.6, activity per microsphere is 150 to 2200. On the other hand, the resin microspheres are bound to the surface of the resin, diameter of 20 to 60, specific gravity 1.6, activity per microsphere is 65 to 140. And as you can see that the glass spheres have, resin microspheres have lower specific activity compared to the glass. So you have to give a larger dose or larger number of particles. Now the glass-based microspheres are delivered as a complete dose with little embolic effect at a potentially greater dosage with larger parenchymal coverage. And specific activity per microsphere is typically greater with glass particles, microspheres, rather than with resin. So these are some differences that have to be kept in mind. What are the contraindications and indications? So we mentioned that it is used, this embolization is used for primary liver malignancy, i.e. hepatocellular carcinoma, cholangiocarcinoma, also for metastatic disease to the liver. The FDA approved indication is for microspheres, resin microspheres, for treatment of unresectable hepatic mets from colorectal cancer with adjuvant intrahepatic arterial chemotherapy of floxuridine. Well, glass microspheres are approved with a humanitarian device exemption as a neoadjuvant therapy to surgery or transplant in patients with unresectable hepatocellular carcinoma. Now, the objectives are to downstage the disease, prolong the recurrence-free and overall survival, and bridge patients for when they're waiting for transplantation or resection. Um, what are the contraindications? I am repeating this, that we do MA scanning and to make sure that it is the particles go to the liver and not elsewhere. So if there is a large shunting to the lungs, obviously it will cause problems, and we don't want that to happen. And main portal vein thrombosis is a relative contraindication. Severe liver dysfunction or pulmonary insufficiency are contraindications. And of course, if you have a bleeding tendency or technical difficulty of catheterizing the hepatic artery. So those are the contraindications. Um, well, caution needs to be exercised if the bilirubin is more than 1.5 milligram per deciliter, or if there is extensive tumor burden with limited hepatic reserve, and then of course patients who have in the past undergone radiation therapy. But these can be decided on a case-to-case basis, and these are relative contraindications. We want to make sure after the treatment we do a three-phase CT scan or MRI and assess the tumor and non-tumor liver volumes, patency of the portal vein, and degree of extrahepatic disease. I beg your pardon, this is a pre-procedural evaluation. Now, follow-up can be done with PET and PET-CT. It is to determine the metabolic tumoral volume in patients who have FDG-avid tumors and establish baseline and follow-up response to therapy. Of course, you need to ascertain what is the hepatic reserve, what is the biochemical status, is there a satisfactory renal function. These are all required to have a good outcome. Now, I'm kind of repeating the information sort of again, and So obviously, one is that we do angiography to map the arteries that are supplying the liver and make sure there is no variant anatomy. And then, of course, we also use MA to ascertain where there is shunting of to the lungs, and if there is variant anatomy, which is typically seen in about 25 to 45% of the patients. Now, conventional hepatic arteries are supplied through the celiac trunk and arise from the proper hepatic artery, which in turn arises from the common hepatic artery. But there can be arterial variants and shunting to the lung, which are important considerations in deciding whether to proceed with therapy or not. Um, Kind of repeating the same story here. Now, when we give MAA, we typically use 4 millicuries, and we we can do a whole liver or more selective administration of MAA, depending on the anatomic distribution of the tumor. Now, the MA particle typical size is 10 to 90, and these are sort of surrogate for microsphere 90 yttrium deposition into the hepatic artery territory. So if there is no shunting, then coil embolization or catheter repositioning. Um, if there is shunting, then coil embolization can be done, or you can reposition the catheter at the time of therapy. Important thing is to avoid any potential complication, i.e., if there is any GI ulcer, pancreatitis, radiation-induced cholecystitis, and pneumonitis. These are the potential complications that can happen if there is shunting. And when we do MAA injections, after that we can do whole body planar imaging of the chest, abdomen, and also do spec CT to see the distribution. This should preferably be done as soon as possible. Large field of view gamma camera with low energy, and you can also use a cobalt transmission source to give you anatomical details. Now, if there is a shunt of more than 20%, these patients are not good candidates because of the high risk of radiation pneumonitis. Well, again, this is not a rule written it's not a strict rule. It can be changed on a case-to-case basis, but remember that if we change the rule, then we have to go down on the dose to spare the lungs if there is more than 20% shunting, and then obviously the suboptimal dose or reduction in dose will obviously render the therapy ineffective. Excuse me. Now, this is an example of a MA image taken from one of my references that I mentioned in the beginning of the lecture. Here you see that the MA image shows uptake in the lungs. This is shunting of the lungs. Now, this is despite a replaced right hepatic artery injection, and the shunt fraction was calculated to be about 55%. Now, that's pretty high, and so decision not to give yttrium therapy was made. Now, yttrium beta particles emitted by yttrium produce secondary Bremsstrahlung radiation, which can be used later on after the deposition of microspheres for imaging. Now, the Bremsstrahlung radiation is caused by beta particle losing energy as it passes close to the atomic nucleus. In other words, as the electrons are losing energy, they are passing as they're passing close to the nucleus of the atom, and these imaging can be done as a planar or spec CT, and these can give us more details about the distribution of the microspheres, and obviously this can help us in detecting any extrahepatic activity. Um, so Bremsstrahlung imaging, we can use medium energy, high resolution collimation, and the important thing is to document post therapy the distribution. This is an example of a post therapy uh, 90 yttrium Bremsstrahlung spec CT, which shows adequate distribution to the right lobe of the liver. And in my next image, this is a distribution to the left lobe of the liver. This is another example of a image that I took from my my reference. Here you're seeing a large tumor mass, highly vascular tumor. On a CT scan, this is the corresponding angiogram showing highly vascular tumor, and there is a selective coiling of a collateral blood vessel. And now, after the therapy, there is a selective, there is a partial response to treatment, and the patient develop progression of the disease. So, in nutshell, yttrium 90 is a very effective treatment both for primary and metastatic cancers.